Well, thank you. I hope we can have a good talk and a good discussion about that subject. And so I'm going to talk to you today about, this afternoon, about small renal masses. So briefly, my talk will be an introduction first, the natural history of small renal masses. I'll talk about active surveillance, briefly about ablative therapies, and then about surgery and a summary. So as you know, small renal masses, they're masses that are less than 4 centimeters, so the T1A, clinically T1A. They're the most commonly diagnosed renal tumors today, between 48 and 66%. And this is probably due to the increased utilization of imaging. We know how many patients we get today in the ER getting CT scans. So most of their tumors, 60% will be local RCC. Aggressive RCC will be only 20%, and 20% will be benign. But this is variable according to the different series. If we look at the natural history of the small renal mass, you can see that also it is very variable. And that meta-analysis, they took 10 papers here with 25 patients per series, and they had a follow-up of 30 months. And as you can see, the mean tumor size was 2.6 centimeters, and the growth rate on average was 0.28 centimeters. So these masses are really slow growing. And the pathology was only available for 46%, and there were RCC in 92% of the cases. So also there's a trend now to use biopsy to diagnose these masses and then to guide our treatment. And the biopsy has really increased once we started doing ablation therapies. And as you can see in the 90s or early to year 2000, it was very minimally used. And the rationale really is that, one, there is no seeding after the biopsy. This is confirmed, very low risk of complication, and the yield is very high. Of course, this is the case in expert centers who do a lot of biopsies. There was this paper published recently in the New England Journal of Medicine, and they looked at the intratumor heterogeneity. They concluded that if you do a single biopsy, then you won't have a good idea about what's happening in that tumor, and that the biopsy won't be enough. But beware, this is a 10 centimeter renal mass, and this was in a patient who had metastasis. So there was another paper published recently that looked at 47 patients, 23 with small renal masses and 24 with large tumors. And they did 3 biopsies in 3 different areas of the tumor. And here, so they look at the genetic variations in those tumors and the copy number variations. And what they found is that in small renal masses, they had less intratumor heterogeneity. So the tumor biopsy is diagnostic in a small renal mass. And they have a good natural history. So which takes us to active surveillance. So if those tumors are slow growing and they're not heterogeneous, then we could monitor those tumors and then do surgery when we have radiological progression. So this is also a meta-analysis about active surveillance. It included 18 studies. I know the Canadians were very active in the active surveillance field, and also in kidney cancer, apart from prostate cancer, of course. They had a follow-up of 40 months. The growth rate was 0.31 centimeter per year, and they had a 2% metastasis rate. And this is a study also that shows how these tumors grow with time, and also with a growth rate of 0.13 centimeters. So it's really variable. They had also this trial, prospective trial, not randomized, where they included patients into surveillance or intervention. And the 5 years cancer-specific survival was 99 and 100% between primary intervention and active surveillance. But if you look at the overall survival, well, this was completely different, 92 versus 75 for the active surveillance, which tells you that those patients, it was not significant, the difference, but already there was a trend to show you that those patients, they were had more comorbidities. There was also that interesting paper that tells us that in patients older than 75, maybe active treatment is not the way to go, and we might not be having an impact on the overall survival. And most of the problems, actually, of the improved survival came from, contrarily, the patients who had increased age and comorbidities had less outcomes, so with the surgery than with surveillance. And mainly, it was deaths from cardiovascular disease. So active surveillance in the elderly population, this is a study, also a systematic review of 17 studies, 36,000 patients, all were retrospective, and there's a low rate of conversion, between 4 and 26%, also very variable to active treatment, and the follow-up was 91 months, so it's quite acceptable. And the overall mortality was substantial in these cohorts, because they were elderly, between 15 and 51%. But the cancer mortality was minimal. So the limitation, we have some studies with intermediate follow-up. We don't have standardized criteria like prostate cancer for intervention. In some cases, we have no pathological diagnosis in those studies, so no biopsies were done. Quality of life and anxiety of the patient also not taken into consideration. And also the oncological outcomes, as I said, some tumors, some biopsies were not done, so maybe they have benign tumors that were not accounted for. So if we look at the guidelines, in small renal masses less than 2 centimeters, this is an option. In patients who have significant competing risk of death, this is also an option. I will move to ablative therapy. So what are the available treatment modalities? So we have cryotherapy, which can be done percutaneously. So this is under local anesthesia with sedation, which is very good outpatient setting. In the elderly patient, this is a very good option. Laparoscopic cryotherapy, we've done that in more complex cases. It has generally good outcomes. This is a study published by the Cleveland Clinic Group with good cancer-specific survival. There is also the RFA, high-frequency ablation, and we do that at our center in AUB. But here, you have to be aware that the limit is the size. So tumors that are less than 3 centimeters will have better results. Of course, the kidney renal function preservation is very high in those ablative therapy, and you can still retreat the patient if there is no success. So this study, again, focuses on the need to do these treatments in patients who have tumors less than 3 centimeters. If it's more than 3 centimeters, the patient should be aware that there is a risk of recurrence. Microwave ablation, also a few studies about it. There is also the IRE, which is the irreversible electroporation, also a few studies on it. I think in the guidelines now, it's mostly RFA and cryotherapy. So which patient would you choose to do partial nephrectomy or ablative techniques? Well, this is an interesting paper that looked at the complications after partial nephrectomy, and mainly age was the most predictor, and the Charlson comorbidity index as well. So if you get a patient who has these comorbidities, then maybe you would favor doing an ablative therapy than surgery. So I think in 2019, we should have ablative therapy in our centers, and cryotherapy, as I said, and RFA are the usually most effective. Now the indications, also we go back to the guidelines. So it is an option in masses that are less than 3 centimeters, but we should have a biopsy if you want to decide to go for surveillance or radiofrequency ablation or cryosurgery. And the patient should know and should be informed that there is a higher local recurrence rate. And now I'll move on to surgery and partial nephrectomy. So partial nephrectomy was at some point underutilized, and we were in anatomically challenging cases doing more radical nephrectomies. And I think especially with the laparoscopy, surgeons tended more to offer minimally invasive surgery, and because partial nephrectomy was more complex laparoscopically, then we would go for a radical. But there was this paper in the Lancet, and I think this changed our practice into doing more nephron-sparing surgery, that shows really that the patient who had a partial nephrectomy did better in terms of chronic kidney disease than those who had a radical nephrectomy. And this was also true in cardiovascular events. Patients who had a radical nephrectomy had more risk of cardiovascular events than those who had nephron-sparing surgery. So which approach would you choose, open versus robotic? Well, we're lucky to have the robot at our center. This is a systematic review and meta-analysis that shows really less complications with the robot compared to the open surgery. So less blood loss, length of stay, warm ischemia time is almost similar, and positive surgical margin is similar as well. This is another study. This is from the French hospitals, 1,800 patients, robotic versus open. And they had also similar results with good outcomes oncologically that were similar in the two, and less complications with the robotics, and less hospital stay. Although in France, I can tell you they keep the patients a little bit longer in the hospital. I like to present that slide, and if you see here, we have the open partial nephrectomy in red, and then minimally invasive surgery, which is laparoscopy, that increased over time, but it was really variable because, as I told you, laparoscopic partial nephrectomy was difficult to adopt. And now, robotic partial nephrectomy is almost taking over. This was 2011. I'm sure in 2019 we have even more and more partial nephrectomies done robotically. So I'll present data from our center. We started doing robotic partial nephrectomies in March 2014. We selected the cases at the beginning. We had no conversion to open surgery. And we've done 109 patients so far. We have data available for 80 patients that were analyzed, and I'll show you the results. The mean size was 3.29 centimeters. We've done some complex cases in patients who were uninephric. We've had patients with factor deficiency. I had one patient with both uninephric and factor deficiency. And some of the patients had previous surgery, colectomies, big midline incisions, incisional hernias, etc. So there was no limitation with that. The age of the patient was 57, BMI 30, so which is in our population in Lebanon, not very obese. And this is distribution of the cases. The PT1A were 70%, so the small renal masses, but we've done some more complex masses and bigger masses. And this is the renal score as well, 47% low, 47% medium, and 5.3 was high renal score. The warm ischemia time was 17 minutes on average, intra-op blood loss 246, but of course this is a surgery that can bleed, so we've had in the maximum a patient that bled 1.2 liters. Actually, the clamp has come off when I realized when I flipped the kidney that the clamp had gone off, but it was too late. I started cutting and removed the tumor. eGFR change was minus 9.34%, and length of stay was 4 days, between 2 and 9 days. So we had no conversions to open surgery. And this is the pathology, was mostly clear cell carcinoma and papillary, and we had some benign cases, but 76% were malignant, and we had 4 patients with positive margins. I have a follow-up now for up to 5 years of those surgery, and none have recurred so far. And these are our complications. We had 2 patients who had hematuria and ileus. We had a grade 2, so transfusion in 4 patients, and embolization in 3 patients. Those were, of course, not the PT1A patients. Those were the larger, more complex tumors. And this is the distribution of the renal score. So as you can see, with time, we are doing more complex cases, more intermediate than low. And we analyzed those data to look at our how we did. And actually, you can see that our OR time was reduced, even though the cases were becoming more complex. But we had almost the same blood loss, ischemia time, and the GFR. And this is our data compared to some other centers who have larger experience than we do, and our data is almost comparable. I'm going to show you a case here of a 67-year-old lady who presented to the emergency department for abdominal pain. And this was actually her pathology. I think she had a very heavy meal, maybe like we did now. And actually, they found a 3.5 centimeter chiral mass in the right kidney. So, of course, in that scenario, in a lady who is fit, and in a tumor which is very close to the hilum, ablation therapy is not an option. So we elected to do robotic partial nephrectomy. I'll show you a small video. I like to use the ultrasound in all the cases, and especially in this one, it's very helpful, or in patients who have endophytic. And we have the picture-in-picture, So here, basically, what I'm doing is dissecting the tumor before clamping. And as you can see, we see the renal vein on the right. That laser is working. And the renal artery I have a vessel loop around them. And I clipped an artery here going directly to the tumor. So it's bleeding because I'm trying to dissect as much as possible before doing the clamping. And now I'm clamping the renal artery. And we'll start excision of the tumor. So I didn't clamp the vein in that case, but usually in hilar tumors on the right side, I have a tendency now to clamp the vein as well, and we have a really clear field when we do that. So this is all cutting in the sinus fat with a good margin on the tumor. Now I flip it to the other side and try to dissect it completely. So I usually use 3 arms now, and now my third arm is not doing anything in that part of the case when I'm doing the dissection. Sometimes I use the third arm just to lift the tumor. And now I'm trying to avoid just the pedicle here and getting closer to the tumor while keeping a good margin. So there was an artery here that was passing. I think it was one of the segmental arteries. So at the end, I repaired it with a proline stitch. This is the tumor. This is the proline stitch here. I just repaired that artery. And there are no vessels in the bed. This is all sinus fat. So what I will do now to close the defect, I use the technique described by Jihad Kawuk, which is the VHS, where actually they put stitches just to get approximate the parenchyma to close that defect. Because if I take sutures now in the renal bed, then it's over. I am doing ischemia to the kidney. So I use a Vicryl, a 2O Vicryl with a large needle, and use Hemolog, so the sliding Hemolog technique. And there you go. You see how that defect will shrink when I pull on my thread, and I put a second Hemolog just to hold it in place. And then I remove the clamp, and there's no bleeding, and then I'll put some hemostatic agent just to sleep well at night. As you see, these are the vessels, and putting some surgery floor there. So in that patient, we had a clear cell RCC, 3.5 centimeters, and the surgical margins were free of tumor. And the clamping time was around 19 minutes. This is her CT post-op after 6 months. And this is her, I saw her in January, and she's doing really fine with a normal GFR and creatinine. So in conclusion, which indication for which patient? Today, there's also by the Cleveland Clinic Group, they looked at the possible algorithm that you get a patient with a small renal mass, you will do a biopsy, and then you will send it for molecular analysis, which is not available yet. And then you can select your patient and discuss with them. If this is a benign tumor, then you will do active surveillance. If it's an indolent cancer, you can choose thermal ablation or even active surveillance. And if this is an aggressive tumor, then you will go for surgery. But until then, I think we should follow the guidelines. And the guidelines are clear. Surgery is the first treatment and the first option. Now, of course, in the elderly, the very comorbid patient, then active surveillance or ablation therapy are also other options that we should consider. Thank you.